For the first question, I'll proceed. JP, it's a common question to ask. And the patients always ask if they have recurrent headache. If they don't have the red flag, they always want to do some kind of scan. Imaging.
Sorry, Hans, can you repeat that? It's kind of
Okay, let's try again. The question is for people for people who appear to have just regular migraine headache without any red flags, but they want to go ahead and do imaging studies all the time. What are your thoughts about this?
Okay. Usually, you don't do imaging studies for those you think or those who would fulfill the criteria for migraine and are neurologically normal when you do examination. Although one indication for doing imaging studies is actually for anxiety. You do have patients who are very anxious, and you may actually do imaging studies to reduce their anxiety, because their anxiety will actually increase their migraine because tension. No? But studies have shown that this only helps for about 3 months. So after 3 months, they may want to ask for another MRI or a CT scan to alleviate anxiety. But yes, you can do imaging studies for that purpose. But normally, well, you try to assure your patient as much as you can.
Some physicians believe that you should undergo a CT scan or MRI at least once in your life if you have these recurrent headaches, or for a diagnosis of migraine. Are your thoughts for this?
Yes, you don't. Yeah, you don't diagnose migraine with imaging studies. Okay, so same thing. If it's typical symptoms and if your neurologic exam is normal, then there's no need for imaging studies. So usually these are only for those with acute headaches, new onset headaches, progressive headaches, headaches associated with other medical problems like fever, or if your neurologic examination is abnormal with weakness or numbness.
Okay, next question. Your thoughts, what are your thoughts on Botox injections for migraine treatment?
That might be useful probably more for tension type, probably. One of the guidelines I've read, it's still unproven, at least for migraine. Okay, so Botox injections for migraine. Maybe tension type headache, maybe. But I haven't seen any new data regarding Botox injections specifically for migraine. Have you seen data for that?
Yes, some data, but they're usually small trials. But I've had some patients who've undergone that and they did really well.
They respond?
Yes, they respond well. Yes. Next question. Given all the medications available for prophylaxis,
yes.
Which one are you most comfortable with or use the most?
I would use propranolol, especially if they're hypertensive. I've also used flunarizine, a calcium channel blocker, and I'm comfortable with that. And pisotefen occasionally. Those are the usual drugs I would use for prophylaxis.
Okay, thank you. I'd also like to add for my own practice, I use pyramid. And it seems to be quite effective. The next typed in question here is...
Pyramid also is.
Okay, next typed in question here is how often is the recommended follow-up and reassessment for migraine reassessment for migraine and primary headache. And
Well, probably every 3 to 6 months would be fine. You just have to advise the patient if the headache frequency is increasing or there's a chance there's a increasing uh, frequency or change in headache character, then they have to follow up earlier. But probably every 3 to 6 months would be fine to check on their if there's not much change in their character or frequency of the migraine headache.
thanks again, JP. I'd like to add
Thanks again,
also,
JP. I'd like to add also,
I attended this session at the EAN in Berlin
recently.
And like you mentioned, there's a lot of work now being done on transcutaneous electrical stimulation. They use electrical stimulators on the forehead.
Yes.
And in addition,
I mentioned that. I think one of the last slides that I showed, and we actually have it here. And I think some of our neurologists are actually using it now.
Absolutely. And the newest part is the transcranial magnetic stimulator. Used once for prophylaxis, prevention. You get several treatments. And the other is they actually have already invented. They've invented a portable TMS machine. And you can see the pictures in
Portable.
Google Images. Yeah, it's portable. So once Google Images. Yeah, it's portable. So once you feel the headache, yes, TMS. Yeah, you can just give yourself the back of your head and then fire it up, and then you get a magnetic impulse, and then your headache disappears. It's amazing. Okay. Now, I think that was the last question. And if there are no more, I'd like to thank all of those of you who have joined. We're now up to 31 on webinar. Thanks for all those who sent in questions. Thanks for all questions. Thank you, Dr. Reyes, for the lecture and for answering all those questions. As a summary, he taught us. Thank you, JP. As a summary, he taught us. Thank you, JP. Our different types of headaches. The primary headaches are more common. But we should be careful to watch out for the secondary types of headache because they may cause morbidity. He mentioned the things to watch out for. In summary, in SNOOPs, which includes older age, sudden onset, having neurologic deficits, systemic findings, or secondary other diseases. Dr. Reyes described so that we can identify them. And then once you have identified them, be able to treat them. Do imaging or spinal tap imaging when necessary. And the treatment involves avoiding triggers, the different choices for acute phase, including triptans, ergotamines, and then preventive treatment, as well as symptomatic, such as for and finally, don't forget to monitor them because sometimes even if it looks like migraine, they may turn out to be something later. So make sure you follow up your patients properly.